So, hello guys, once again, welcome to our medicine lectures. So, we directly beginning our second session of cardiac pathology. We've done development of the heart. We're doing now the congenital anomalies of the heart. It was so difficult for us to begin doing the congenital anomalies of the heart without actually understanding the development or the developmental stages of the heart. It's very important for us to understand those parts. Very, very crucial. So straight without having any wastage of time, uh, the congenital cardiac anomalies is usually 0.4 to 0.5% of all the births in the world in a year. And so it affects more males actually than females for many unknown reasons. And it has many causes that are probable and risk factors. So many risk factors can be traced to be correlated to the congenital malformations of the heart, and actually you can, or they can be proved to be 90% or 70% cause that leads to a congenital cardiac anomaly. And sometimes you realize that congenital cardiac disorders are the causes are multifactorial, in the sense that it's not one isolated factor that is going to contribute to these anomalies, but many other factors are joined together. They're going to give us these disorders. So the first common cause is the rubella virus. We have the other drugs. Some drugs have been implicated in the causation of the cardiac disorders. Also, um, maternal age, mothers above 35 years have been implicated to have their first pregnancies, their children or their firstborns are affected with these disorders. Um, Also, environment, where someone has been exposed to radiation such as gamma rays, severe X-rays, and nuclear radiations have been implicated to these disorders. So all these multifactorial stuff have been implicated to the um, to congenital cardiac anomalies. In this manner, and then we can classify them into three major classification. We have malpositions. The heart usually is on the left side, but sometimes you can find it on the right side of the body, so it's called dextrocardia. So malposition and usually dextrocardia, where the heart is on the right side of the thorax. That's commonly abnormal. Then we can have shunts. It's very good for you to go through the video that we've already done. It's the congenital cardiac anomalies or the development of the heart. It gives us a basis on septations, the formation of the ventricles, the formation of the atria, the formation of the septum between the arteries, between the ventricles, the interventricular septum, that's the interarterial septum, and then the interventricular septum, interventricular septum, and all those. We've done already the between the aorta and the pulmonary trunk. We've already done that, how you make the septum and how the heart develops. So it will give you a hint on how we going to have uh foraminas, or the communication that is not required, or the shunts in the heart, and they are known as shunts. So we've said we will have malformations, we will have shunts, and we'll have obstructions. So in the malpositions, we've handled dextrocardia. The heart is in a wrong side of the thoracic cage, is on the right side of the thorax. But when we come to shunts, we're going to have two types. One, we're going to have cyanotic, acyanotic, and then we have obstructions. So once again, we've said we have malpositions of the heart, we have shunts, cyanotic, acyanotic. The cyanotic can be known as right to left, and acyanotic can be left to right. Then we can have obstructions. Having done malpositions, let us begin with the shunts of cyanotic nature, which are actually um, um, right to left shunts. The first one is Tetralogy of Fallot. As the word, we have almost four of them. We have Tetralogy of Fallot, we have transposition of great arteries, we have persistent truncus arteriosus. It's very good. You go through the development of the heart, you will find that we handled the truncus arteriosus, which gives us the ascending aorta, and it's giving us the pulmonary trunk. So septation between the two, it's going to give us the two common arteries that are originating from the ventricles, from the left ventricles, the ascending aorta, and from the right ventricles, with the ventricle, we're going to have pulmonary trunk. So the truncus arteriosus is actually a common loop, a common channel, a common tube that is going to be septed to give us the aorta and the pulmonary trunk. So if you're going to have persistent truncus arteriosus, you're going to have a problem. We can also have tricuspid atresia and stenosis. Let us begin with, we can actually begin with the Tetralogy of Fallot. We can begin with Tetralogy of Fallot, and remember, it's the first in our right to left shunt, commonly known as cyanotic shunt, cyanotic cardiac shunt. In this, it actually contributes to 6 to 15% of all documented cardiac anomalies. So of all the documented cardiac anomalies, the Tetralogy of Fallot contributes to 6 to 15% of these anomalies. Now, question: what's the Tetralogy of Fallot? The Tetralogy of Fallot, from the word tetra, it has 4 anomalies. So the first problem you're going to have is ventricular septal defect, usually membranous part. So interventricular septum has 2 composition. We have membranous part, which is cephalic, and we have the muscular part, which is caudal. And then in the Tetralogy of Fallot, you said tetra, we have 4 anomalies. The first anomaly we're going to have is ventricular septal defect. Usually, you have a foramen at the level of the membranous part of the interventricular septum. The second problem you are going to have in Tetralogy of Fallot for anomalies is displacement of the aorta to the right side or to the right side. It's usually known as overriding of aorta. So the aorta is going to override the VSD that we've talked about. So we have membranous part, the shunt is on the membranous part. Then it means if this is the right ventricle, and this is the right ventricle, and this is the left ventricle, it means what you're going to this is the left ventricle and this is the right ventricle. So what you're going to experience is that you have an abnormal opening between the two, then the aorta should actually be getting blood out of the left ventricle. So the aorta is going to override this foramina, and then it positions itself on the right ventricle. Okay, number one, we've said we have ventricular septal defect. Then the aorta that should be draining blood from the left or receiving blood from the left ventricle is going to override this membranous as part of the septum to actually be positioned on the right side of the ventricle. And then we're going to have pulmonary stenosis and then right ventricular hypertrophy. So the pulmonary stenosis and right ventricular hypertrophy, it goes without saying that if we have a stenosed, narrowed right pulmonary trunk, we're going to have a strained right ventricles. So the strained right ventricles are going to, the heart is going to compensate to hypertrophy. So we have for the Tetralogy of Fallot, we have overriding of aorta. It overrides uh, the ventricular septal defect. That's a shunt that is there already. And then we have a stenosed pulmonary trunk, and then we are having a hypertrophic right ventricles. That's the Tetralogy of Fallot. And it's the commonest in cyanotic heart diseases. So if you see a baby presenting to you at birth or few hours after birth, and then the complaint is about central cyanosis. We said the mucous membrane, the lips and the tongue are bluish. This baby is most likely suffering from something we call tetralogy of Fallot. It's the most common cause of cyanotic congenital cardiac anomalies. We also have transposition of great vessels, in which is not common. It contributes to 6 or 4 to 10% of right to left shunts, where you find that the pulmonary trunk is draining blood from the left ventricle, taking to the lungs. And then we're going to have the aorta draining actually blood from the right ventricle, taking to the systemic. This is going to give us a bluish signs and symptoms of the affected child. So transposition of great arteries is the second most in cyanotic congenital heart diseases. We also have persistent truncus arteriosus, in which blood generally is mixing in the common loop, in the common tube that never was septed. And usually it's caused by a failure of migration of neurocrest cells, which assists in the partitioning of the common truncus arteriosus to give us the ascending aorta and also give us the the pulmonary trunk. So we also have tricuspid atresia, where the valves or the cusps between on the right side of the heart are atresia. They are not patterned. So what it means, you're not going to receive blood from systemic to come to the right ventricle so that it can be pumped to the pulmonary system so that it can be oxygenated. And that's why the patient is going to present with cyanosis. We can also have so cyanotic group, as we've said, transposition of great vessels, where you have the aorta originating from the right ventricle and you're going to have the pulmonary trunk originating from the left ventricle, and the consequence is very, very, it goes without saying that the consequence is you're going to receive blood from the left ventricle going to the lungs again. You're going to receive blood from the right ventricle that is deoxygenated, pumped to the aorta, to the systemic. That's why the patient is going to present with cyanosis, and usually central cyanosis. All the anomalies of the heart that are cyanotic, they are going to give us central cyanosis. Then we have persistent truncus arteriosus, common loop. We're going to have tricuspid atresia. It's not going to permit blood from the right atrium to the right ventricle so that it can be pumped to the pulmonary trunk so that it can go to the lungs for oxygenation. So they are the second most common. In this group, the Tetralogy of Fallot, which has 4 anomalies, tetra, that has the ventricular septal defect. We have also the overriding of aorta, in which now the origin of the aorta is no longer, or the outlet of the outflow, the bulbus cordis, the part of the aorta is no longer on the left ventricle, is actually on the right ventricle. Is that foramina, like the origin of the aorta, is from the right side of the ventricle, or the right ventricle. Then we're going to have pulmonary stenosis, and we are going to have right ventricular hypertrophy. So we have handled those, and we've handled them in the hierarchy of their frequency: the Tetralogy of Fallot, transposition of great vessels. We are going to have persistent truncus arteriosus. We're going to have tricuspid atresia. They are in such frequency: 6 to 15%, 4 to 10%, 2%, and 1%. Left to right shunt, a cyanotic or late cyanotic group, we have ventricular septal defect, the most common. Once again, a cyanotic, the patient in the early stages is not cyanotic. However, most of these conditions, as they progress, the patient is going to have cyanosis, and we're going to explain later as we move by. So, VSD is acyanotic, ventricular septal defect, because the left side of the heart has more is a higher pressure zone compared to the right side of the heart. So when you have a ventricular septal defect, any foramina, any communication between the ventricles, it's going to permit blood from the left side to the right side until we have compensation, when the right side of the heart is going to begin compensating. The compensation is going to give us um, the compensation is going to give us hypertrophy and hyperplasia of the right side of the heart, and eventually we're going to have a stronger right side which can actually resist the pressure from the left side of the heart. So you want to have late cyanotic condition. So it's early acyanotic, but late cyanotic. Why? Because of the compensatory mechanism that we can see from the right-sided right side of the heart. So we have the ventricular septal defect, we have the atrial septal defect, we also have the patent ductus arteriosus. Patent ductus arteriosus, which usually sends blood uh, from in utero. It actually sends blood from the 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 the, the pulmonary trunk to the descending aorta, of the arch of aorta, and then we have the atrial septal defect. So ventricular septal defect, most common, and then the atrial defect, second most common, 10 to 15%, and then we have patent ductus arteriosus. It's also very common, 10 to 20%. So we can also have obstructions, where we can have congenital obstructions of the disease, where you can have coarctation of aorta. The heart is narrow, or the aorta is narrowed. You can also have aortic stenosis, atresia, failure to have patency, or the lumen is not patent. Then we have pulmonary stenosis or atresia. So you can have coarctation of aorta, this narrowing of the aorta, and then you can have aortic stenosis. You can have also pulmonary stenosis. So in a nutshell, those are the congenital cardiac anomalies that you can actually find. Thank you. Until we meet in the next video.